Hi there, everyone. Very excited to be here today from Memorial University in Newfoundland. This is a project I did with my preceptors as part of my master's. I'm a general surgery resident at Memorial. Nothing to disclose. So briefly, the impetus for this research question is, as we talked about, the encouragement from ERAS to avoid opioids perioperatively. We've heard a little bit about it, and we'll hear more about it later today. But then the question comes, what is the alternative to opioid analgesia, and are they safe? There have been several animal studies in the last decade and a half that have looked at NSAIDs following anastomotic formation. The data isn't uniform, but there does seem to be a general trend looking at it towards increased leak rates with NSAID utilization. Interestingly, if you look at it, there does also appear to be a location-dependent effect, whereby the small bowel is affected to a much greater degree than the large bowel. For the sake of time, I'm not going to get into the pathophys of this too much, but it seems to have to do with COX-2 expression in the small bowel in comparison to the large bowel. Looking at previous meta-analysis on this topic, there have been a few. Again, no uniform effect, but it does appear like there's a trend towards increased leak rates with NSAID usage after colonic and rectal surgery. So our research question, does NSAID administration given after colonic or rectal surgery cause an increased leak rate? So why are we doing this study if it's been done before? So there's a couple new takes that we took on this. One, given the previous animal study research that we looked at and we found the location-dependent effect, we decided to only look at colonic and rectal anastomosis and not group this together with intestinal anastomotic healing. Secondly, we only wanted to include studies that were powered and designed to look at anastomotic leakage as the primary outcome. So if you look at all the previous meta-analysis, they all primarily use studies that are designed for another outcome, usually other sequelae of NSAID usage, such as decreased ileus postoperatively, and they just make a side note. So one person in this group had a leak, or two people in this group had a leak, and so they're not designed to look at leakage. So that's something that we tried to look for. So just quickly, I'll go through this. Our PICO, our patient population were patients who underwent a colonic or rectal anastomosis. Administration of an NSAID in the first week was compared to no NSAIDs in the first week. And primarily, we looked at postoperative leak rates, but also we performed subgroup analysis looking at selective and non-selective NSAIDs. We took on randomized and observational data. We took a very broad search strategy, and the screening and selection was performed by myself and one other researcher. I won't go into this too much, but we used an odds ratio as well as a random effects model, assuming that clinical practice is somewhat heterogeneous based on hospital and location, and used the I-square statistic to assess interstudy heterogeneity. So this is our PRISMA, pretty thorough search that in the end brought us down to about 7 articles. Primary reason that articles were excluded had to do with either they weren't designed to look at anastomotic leakage as their primary outcome, they combined modalities, for example, steroids and NSAIDs, or they were studies that combined small bowel and large bowel anastomoses as one group and not delineate between the two of them. So these are our 7 studies. Took place across Europe and North America. Unfortunately, all observational. So we could not find any randomized studies that have looked at NSAID usage with anastomotic leakage as their primary outcome. So certainly something for future consideration. And came up to about 9,800 patients in the end. We use the Cochrane risk of bias tool for observational studies. This stratifies cases into 4 categories: low, medium, serious, and critical risk, with critical risk studies being excluded. This is our risk of bias table. Before the start of the study, we had decided upon key confounding variables that needed to be taken into account by each of these studies. The ones that were deemed moderate, they were studies that did take into account these confounding variables. However, they had significantly different numbers of patients in the intervention and control group with respect to these variables. Interestingly, 3 of these 4 actually had a bias towards underestimating the effects. So the NSAID group had patients that had higher comorbidities than the non-NSAID group. And 3 of these studies were deemed serious risk because they did not mention certain confounding variables that we thought were important, such as protective ileostomy, colonic versus rectal anastomosis, or smoking, etc. So these are our results. This is overall NSAIDs grouped as one class and looking at colonic and rectal anastomotic leak rates. So as you can see, there is a significant leak rate that we found, and this correlates quite well with previous meta-analyses that have been done. Then we broke this down and looked at non-selective NSAIDs, and once again, we found a similar effect. So then we went and looked at two of the most common medications that are used in the literature, diclofenac and ketorolac, both classified as non-selective NSAIDs, although diclofenac is quite interesting because it has an inhibitory profile. It tends to lean towards COX-2 inhibition like a selective, but it's still technically a non-selective NSAID. And we found significant leak rates with diclofenac, but not with ketorolac. This is our intergroup bias funnel plot, which is fairly symmetric. So our conclusion, NSAIDs are associated with an increased risk of anastomotic leakage after colonic and rectal surgery. Non-selective NSAIDs in particular are associated with an increased risk. But this effect is not consistent across all NSAIDs. So we are one of the first ones to look at a location-dependent effect on this question. Rather than grouping all anastomoses together, we looked at just colonic and rectal anastomoses and isolated small bowel anastomoses. And we also were the first ones to look at just studies that were designed and powered to look at postoperative anastomotic leakage with NSAIDs. But this leads to our limitation. This significantly limited the number of studies that we have in our meta-analysis. So in comparison to a lot of the other meta-analyses which have greater numbers of patients and studies, we were limited to primarily observational data, which led to the inherent risk of bias with confounding variables not being taken into account, which is where randomized data would be nice in the future. Also because of this, we had very limited numbers of selective NSAIDs included. We only had one study that looked at selective NSAIDs. They did not find a significant association, but it's very difficult to make a claim based on one study. Again, we also started this discussion regarding location-dependent effect, but I think there's a lot more room to go. We didn't delineate colonic versus rectal anastomoses. We didn't delineate proximal versus distal colonic anastomoses, which if you look at a lot of these animal studies, the proximal colon seems to display COX-2 properties very similar to small intestinal anastomoses versus the distal colon, which has very little COX-2 expression after resection anastomoses. So our conclusion, as mentioned, there is an increased risk within the first week, but I think the most important thing is that line on the bottom. I think we need more research, better research, and I think over time what we need to do is delineate not only are NSAIDs safe, but which NSAIDs are safe. I think this is quite a heterogeneous class of medications. I think some will be proven to be safe, but some won't be. And so further high-quality randomized data should be able to give us better guidelines to guide our practice. Thank you.